Okay, good morning, everyone. Thanks for joining us again for Discussions in Diagnosis. I'm Goutham. I'm the director of the UH Advanced Center, which is dedicated to identifying best practices for diagnosis for common but challenging problems. And today we are very pleased to welcome Dr. Erin Babbitt, who is a neuropsychologist here at University Hospitals here since 2015, I believe, who specializes in two important areas. One is the neuropsychological manifestations of brain tumors in children, as well as other neurological conditions, but also in autism and autism spectrum disorder, which is what we're going to be speaking with her about this morning. So thank you for joining us, Erin.
Thank you so much for having me. This is great. I love all the early birds. This is fantastic.
Well, it's got to be early because we've got to get on with other parts of our day.
That's right.
So we're here to talk about autism spectrum disorder. And why don't we start with the basics? If you could tell us, everybody knows the definition changed in 2013, and there isn't a lot of confusion about that. But let's start by defining autism spectrum disorder and its key features.
Sure, absolutely. So I think autism is kind of conceptualized best as divided into social communication difficulties and some emotional behavioral difficulties. And so when you're looking at diagnosing autism, when you're looking at difficulties with social communication, usually falls into three areas. One is reciprocation and conversation. So that could be anything as mild as having a hard time keeping up with like the back and forth of conversation. People may just, tend to be on their own thought process and not be able to reciprocate well, all the way to literally no initiation or maintenance of conversation at all. So again, as we know, this is a spectrum and has a variety of different presentations. There's also difficulties with making and maintaining relationships. Again, can be as subtle as someone who is actually quite socially motivated, but is just quite awkward in their interactions and makes a lot of mistakes in relationships. So problems with really maintaining those deeper relationships over time, all the way from what's seen as a lack of motivation to even engage with others. And then the nonverbal communication piece is really important. And I think with, again, that more mild presentation, you can have good eye contact. You can have somebody gesturing and showing some emotion in their face, but maybe it's not well timed, their verbal and their nonverbal communication. So it's a little awkward, and all the way to very flat affect and lack of eye contact. So again, a wide variety of those presentations. When it comes to the emotional behavioral piece, that's where you start to come across some of the other pieces of autism required for a diagnosis. Usually it's only two of these things, whereas the social communication, you needed all of those areas to be fulfilled. These include things like that hypo and hypersensitivity to sensory stimuli. So these are individuals that have sensory aversions, bright lights, loud noises, textures of clothes, textures of food, to any individuals that also have hyposensitivity. So, pain is not something that they're very sensitive to, or cold or hot. So you can have, sensory averse behaviors and then actually sensory seeking behaviors, where they're trying to get more out of their environment than most of us would need to in order to feel kind of stabilized. Insistence on sameness is a very common component to autism. This can be anything from just being a very big stickler to routine, and feeling very upset when that routine is interrupted, to having rituals that need to happen every single day, and so problems with transition on routine, and then with repetitive, I'm like, what am I thinking of? With repetitive behaviors as well. This may or may not be present in individuals with autism. And so those can be some of the more classic, like hand flapping behaviors, all the way to things like verbalizations, that are done over and over again. I've seen some of the higher functioning kids who pace back and forth quite a bit, or, meow on a consistent basis. And so there's these, repetitive behaviors. And then finally, there can be a highly restricted interest. And so these can be very odd and age inappropriate. So I've seen kids, obsessed with plungers. And then I've also seen kids where the obsession is actually quite age appropriate, but a little too hyper focused. So things like sports or video games is a big one. So that's kind of autism in a nutshell.
Wow, thank you for that great overview, Erin. And so the next question I want to get to is the prevalence, because you read a lot about this, and it's always kind of quoted as 1.7%, 2%, 1 out of every 50 kids roughly, which means that we all, if we have 50 kids in our practices, have at least one child who has autism. The other controversy is it seems to be increasing. And what are your thoughts about that? Is it due to better surveillance, better screening, or are we seeing it, or is it changing definitions? What give us an idea of what your thoughts are about prevalence?
Yeah, I think we could probably talk about this all day. I get these questions quite a bit. And I think now, we've got a quoted prevalence of like 1 in 44 now, through the CDC. So just over 2%. And I do get this question a lot. And I think, it is a combination of multiple factors. One is we have such greater just global awareness in general, a lot more public policy kind of pushing for identifying autism and providing services that autistic individuals need. So just the awareness in general. I think we are getting better at identifying autism in the more mild presentations. And I say mild, but these are autism spectrum disorders. This is we give the diagnosis because they do have an impact in their functioning, but may not be so obvious in their presentation to us. And that's including all like girls, for example. We're getting better at identifying autism in girls, which was a lot more difficult in the past and still is now. And so there's those factors, but also there are factors that we just don't understand yet, because those don't really make up for this increase in prevalence. We can't just say, oh, we're better at identifying it. So genetic factors, environmental factors, things that we're just not aware of yet, and continuing to do research in.
Okay, so still some outstanding questions there.
Yeah.
I want to get back to the clinical picture and the settings in which I practice, and most of us do practice. And as you know, the AAP recommends screening for autism at both 18 months of age. This is in addition to regular developmental screening. Right. At 18 months of age and at 24 months of age, the U.S. Preventive Services Task Force has not found sufficient evidence to make a screening recommendation, but is in the process of updating its recommendations as we speak. Can you talk a little bit about screening tools for autism? It's the MChat. The MChat is incorporated, for example, in the EPIC electronic health record system, which we're implementing right now. And what are your recommendations about how we use them and whether they're useful or not?
Yeah, so I'm a big proponent of screening for autism for kids where there's a concern. So that could be from parents or the physicians themselves. So, if something comes up in the regular developmental visit, those screens are there for a reason. I think for a couple reasons, really. One is just the psychological impact for parents of having a conversation with their physician about their concerns. When the physician brings out something that's, more of an objective measure that shows the parent that they're being listened to and that this is taken seriously. And, whether or not it's used more globally is another thing, right? Because that task force is really saying, what are the pros to really screening everyone no matter what, regardless of whether or not there's a concern. And that could place some undue burden on families as far as, moving forward to getting further evaluation if indeed there's a false positive. But my recommendation has always been, when in doubt, if there's a concern, these screens take 5 to 10 minutes. The MChat especially has good positive predictive value, good specificity, is often used by my colleagues in developmental pediatrics. I assess kids 5 and up, so it doesn't come up a lot in my practice. But I do know that it is a very helpful measure, again, not just to pick up on some of the more obvious signals of autism at a young age, if it is going to present early, but having that conversation with parents is extremely important so they feel heard and validated. And we do know that early screening leads to early intervention and early resource, getting those early resources in place.
Thank you, Erin. So I think that's a strong case for the value of screening. And as an interlude, we can talk about how we would do that in primary care. There's at least a few different models. The electronic version in Epic, for example, the MA sits down with the parent and said, let's go through this together. That's one approach to it. Alternatively, I think it works just as well, is a paper copy that's given to the parent to complete. I've seen some of those not great completion rates, but the physician can then come in and then finish it off and then record the score in Epic. And then, there may be some recommendations to go forth after that.
Yeah.
So that raises the next question. And I've certainly, I've supervised both family medicine residents and pediatrics residents for a very long time. And I often hear this when you ask them, did you screen for autism? And they say, oh, no, I know for sure this kid is not autistic. I also know that sometimes you talked about some of the features early on. They do a very quick pretend play. So give them your cell phone or mom's cell phone and see if the child at 18 months puts it up to their ear, calls out their name, and then looks for joint attention, gives the child some object in the room or some toy, which the child hopefully will share the experience with their parent or with someone else because they're excited about it. And that is the extent of what they do if they do that. So can you talk a little bit about our own intuition? Because this is really the core of our diagnostic center is best practices. How good are we at picking up autism without these tools?
We're not. And frankly, first, I want to commend any physician who is employing some of these basic screens, even if it is very informal. Fantastic. Again, it presents a conversation to the parent. This is what I'm doing right now. This is what I'm looking for. And maybe they seem fine in all of those aspects. And that's great. Most of the kids that I see, however, later on in life are kids that would have passed these MChats just fine. That we're utilizing a lot of these skills that we're looking for to be absent early on, and I'm demonstrating these. So it doesn't mean that, if you're seeing a 24-month-old and you're implementing these screens and you're doing the MChat, everything comes out fine. It doesn't mean you're not doing a good job of moving forward, and maybe that conversation needs to be had another time if concerns be brought up. But to be so absolute and say, you know what, there's no issue here. There's no issue here. I do encourage physicians to listen to parents, because what I get a lot is in that one-on-one physician setting, you have a 4, 5, 6-year-old who comes in, they're looking at you, they're pointing to the picture of the basketball on the wall, they're talking to you all about sports, they're engaging with you, you get to talk about your kids' interest in sports and they're talking about theirs. And it's this amazing conversation that you're having. And you're like, absolutely not. This is not a kid who has autism. He's looking at me, he's gesturing, he's having a back and forth conversation. But I do urge you to listen to that parent, because outside of those 4 walls, outside of that one-on-one setting with an adult, this could be the same kid that all he's doing is talking about sports. He's not even very good at sports. And then he has his own rules for his sports games. Nobody wants to listen to him because he's exhausting them. And then because he went to that doctor's appointment, he's so out of his routine that he tantrums for the rest of the day. He's rocking himself to sleep at night to self-soothe. He needs big bear hugs. He's closing his ears because he's overly sensitive to noise all day. So again, it just becomes this outside of that doctor's office. It's a completely different issue. And it is impacting them to a significant degree where they're not maintaining friendships, and the sensory issues and the restricted interests are just getting in the way. So absolutely do your best at those early ages and be very helpful with parents and saying, look what I'm seeing. This is great. But also if they come back a couple years later, it's like, it's just not working out. They're in preschool now and things just aren't working out. Have that conversation and take an interest, and then move forward with further evaluation as needed.
Wow, terrific. Yeah, it's a very strong case for both surveillance and for screening. So I think that raises another question. I've read that we know that sometimes when this is identified early, there are some positive benefits in children. Some teenagers, some adults, young adults no longer meet the criteria for autism spectrum disorder. So I think the consensus now is there is value to early identification. And at the very least, it helps the parents and the family understand the illness and get support, even though it's not necessarily going to improve over time. So it raises the question, Erin, what should I do? I have a positive MChat, and let's say I instituted the MChat not as a screening measure, but because I have suspicions that the parent raises concerns. Now, where do I go with that?
Very first and foremost, the least you could do and the best you could do in that situation is have a conversation with the parent. It takes 30 seconds to a minute, even if they don't have concerns, but you do. You can say that you're noticing these things, that this is a measure that you often use in order to, wonder about autism. And some of these things seem to be coming up. There could be all different reasons why this is happening. But we definitely want to take this seriously. And if the parent then meets you there, then, moving forward with either a further conversation with yourself or then a specialist. Sometimes those are visits with a developmental pediatrician, and depending on the age, a clinical psychologist, someone who can, interact with with that child and do a little bit more assessment. There's also, for the older kids, some other screening measures. So if you have kids that are a little bit more school aged, things like the SRS-2, Social Responsiveness Scale, can give you some input from teachers. So maybe, it's not a bad thing to say, hey, I have this other measure that I want you to fill out, and maybe the teacher fill out and return back to me. And again, it's more for monitoring. So you kind of meet the parent where they're at. If they're saying absolutely no problem, that's okay. Here's my concern, and here's what I want you to look for, mom and dad. And then I'll see you back next time and we'll talk some more. Not letting it go, but making sure you're meeting them where they're at, so they're continuing to trust you and have a seed planted in their head on what they need to look for. And then if they do meet you if there is some concern, absolutely moving forward and referring on to a specialist to kind of do a little bit more investigating.
Yeah, that's a great sort of shared decision-making approach where we're having that discussion with the parent and say, well, let's hold off or let's continue to monitor, which I think is reasonable.
Absolutely. Yeah. And again, another thing too is, even if they're not ready for autism and, going through with all of this, are there some things that they can start doing with their child to improve social emotional reciprocity? And that can be fun things, right? Let's maybe set up some more play dates, or, let's do some more after school activities or something, just so they can, again, you've planted the seed, you're having them engage in things that they're engaging in every day, but being just a little bit more cognizant of. And so that way they trust you and can come back to you and be like, okay, you know what, we did try more play dates and it didn't work out.
Great, thank you. So the last major question I want to talk about is things we don't know, or the big gaps both in practice and diagnosis. And to give you a couple of examples, we know that minority children are sometimes diagnosed at a later age or less likely to be referred, and nobody knows why. It may be because parents are less likely to raise concerns. It may be because the healthcare delivery system is not delivering what it promises. Girls, again, you mentioned early on, more difficult to make a diagnosis. So what do you see, Erin, as kind of the big things, the big unknowns right now that we still need to work on?
I'm very proud of our field and some of the endeavors we have now looking at the minority population and girls and these different presentations. And I'm happy and satisfied that a lot more research and money is being put into that. I think where I come from and with these older kid populations, my biggest issue is that independent functioning piece. I believe that, we know like up to a third of kids with autism can have an intellectual impairment. And so obviously there's that cognitive piece along with the social and behavioral component that impacts their ability to become independent as an adult. But even the individuals who have average to above average intellect, so the kids who are talking and bright and full of life and doing all of these things that on the surface appear to be an indicator of good intellectual ability, that IQ score on paper is not translating to then eventual good independent functioning later in life. And so my big thing is, why is that? Why in kids that have, good intellectual functioning and language functioning, are they not brushing their teeth, taking a shower, being able to do the things that can get them into post-secondary schooling and occupational settings where they can really be at their best as an adult. And I have multiple hypotheses as what that is, but I think it's important that we really start to focus on some of these quote unquote higher functioning kids, because as the more that we can start to work with parents on closing that gap between what their functioning is looking like on paper and how they're actually doing in daily life from a self-care perspective, I think the better we are to then close that gap and get these kids to the best of their abilities. And so I think there is this kind of lull in real research on, we have a lot of nice, pretty things on paper, but how are these kids actually functioning once they become adults? And it's not looking good.
Wow, great thoughts. And those are some very important gaps to address. So I'm going to throw it open to everybody now. If you have any questions or comments to share with us this morning, please make sure you unmute first.
Good morning. This is Brian Zach. How are you?
Hi.
Hey, Brian.
I've had the pleasure of actually working twice this month with Erin on different presentations. So this is fantastic. I just want to re-emphasize for the group one of the earlier points that both of you made, which is the screens don't pick up everybody, but in a pediatric practice, the most important part of this is the discussion. It's the relationship with the parents and empowering them to ask questions and to understand why you're asking the questions you're asking. Sometimes they don't bring it in. Sometimes they do bring up concerns. The other thing that I want to also comment and get Erin's feedback on is with any test we look at sensitivity and specificity, looking for false positives and false negatives. This is a topic which can be really anxiety provoking for parents, especially first-time parents who want to make the world perfect for their child. So my question for Erin, in terms of her to bring to the group, is we get lots of questions in pediatrics, and I'm sure family medicine as well, in terms of my child's doing some head banging during bedtime routine. My child has some hand gestures I find interesting. When do we take that kind? I know those are just two examples. I'm not trying to limit it to those or even have you discuss those two. But broadly, some of the times parents bring us a specific behavior. What's a great way to answer them, but also not dismiss, but also not provoke? I know it's generic, but I think it's really important because it will affect downstream conversations with the family.
Yeah, that's a great question, Ryan. Go ahead.
That is a really good question. And so, I think you do this with lots of things, right? Whether it be if you're a primary care physician and you're dealing with a cold, a parent might be concerned about one symptom that might be, oh my gosh, this could be something more serious. And so I think, with your ability to have this conversation with a parent, you're in a situation where you want to obviously validate the fact that, oh, I see what you're saying. And yes, there are kids with autism that can have these behaviors. Let's sit down and talk about some other things. How do you feel about their social skills, how do you feel, and kind of go through other areas of autism that would be apparent in this population, because we do know that there's kids that headbang and there's kids that rock themselves to sleep, and this can be a natural part of development. So it's like, I'm hearing what you're saying, and you're right. You can see this in kids with autism. You also can see this in typically developing kids. So let's further this discussion a little bit more. How do you feel about how they're giving you affection? Do you feel like they're sharing with you when you play? Do you feel like they're connecting with other little kids, at their daycare or preschool setting? Do your teachers have concerns? And again, if they say, oh, no, none of that, just the head banging, it's like, and not to say, oh, well, then no autism, right? It's just like, well, you know what? At this point, I'm hearing what you're saying. It's definitely something that I'm hearing you're concerned about. Looking at these other factors, it sounds like he's doing pretty well, but let's keep an eye on it, and I'll follow up with you in 6 months, or, talk to some teachers and see how he's doing at school. So kind of, again, a shared ability to educate the parent on what autism is, meeting them where they're at, showing some empathy, keep making it so you're taking them seriously and they feel like that. And then knowing that you're there for them in 6 months, maybe after they've looked at other things in this kid's life, they can bring back to you and you can move from there.
Great advice and great question, Brian. I think, the message I'm getting from Erin in particular is this is not a one-time thing. Oh yeah, your kid's autistic, your kid's not autistic. And we say this a lot. I say this a lot to both adults and children. I can't figure this out on one visit. It's going to take us some time to get there. I appreciate your concerns. Let's keep it in mind. Let's see you again. So terrific question. We'll take one more question or comment before we got to wrap up.
Hey, this
Go
is
ahead.
Liquid Family Medicine. I'm thinking back to like a worst case scenario that when I was a resident, and we had basically made this diagnosis through the MChat, and parents were both just like livid, literally stormed out of the office.
Mm-hmm.
Were lost to follow up, and I was wondering if Dr. Babbitt, if you have any idea of like any tactics that have ever worked in that like worst case scenario.
Yeah, that's happened to me too, Kevin, actually. Go ahead, Erin.
Yeah. And so I think it's, I deal with kids all the time that have intellectual disabilities that the parents don't know about either, right? And so, and I do a lot more exhaustive assessment, right, where I'm leading to a diagnosis. So I think with the screens, it's important that parents understand that these are not diagnostic in and of themselves, right? This number on a piece of paper does not say, okay, now your child has autism. Again, you have to meet the parent where they're at, because just like you noticed at that incident that was probably traumatic for you and them, they hear one thing, they're never going to come back to you if they've lost that trust in you. And so the idea is like, if this is part of our normal developmental screen, I noticed that some of the things that you mentioned on here, like this, and this, we can see that in kids that have developmental differences, such as autism spectrum disorder. Has that ever been a concern of yours? Oh, absolutely not. No, we would never. Okay. Well, here are some things that, parents of kids with autism often mention are difficulties. And you can even say that, here's some things that they've mentioned, difficulties with relationship or peer-to-peer relationships, blah, blah, blah. Are you sure that's not anything you've noticed? No. Okay. Well, thank you so much for having this discussion with me and letting me be a part of your child's care. We always have to monitor. We always have to check in. So, just keep an eye out for these things, and I'll see you back next time.
Yeah, great suggestions, Erin. And Kevin, I can make one suggestion as we move towards EPIC and we incorporate this into the electronic health record or even on paper. Do not, discourage your MAs from discussing the results of the MChat with the parent.
Yeah.
Let them fill it out. And if the parent asks, they say, well, Dr. Kowalik will be in a few minutes to go over the results with you. The incidents that I've been familiar with is the MA telling them, oh, your kid scored positive for autism. Of course, they're going to be livid about it. And that's not exactly what happened. So let's keep that in mind from a workflow.
Yeah, and I do want to say, even in evaluation, it's important for everyone to know that the ADOS, that gold standard of autism assessment, is not diagnostic. A positive score or a negative score doesn't mean yes or no autism. Autism is a clinical diagnosis. You need to have a thorough social, emotional, developmental, behavioral interview. You have to have collateral information. You can't just look at a score. It's not like a blood test where you look at a score and you say, okay, this must be autism. So any kind of dramatic conclusions made from a screen is really not the right way to go. And so more of this conversation needs to be had with screening rather than, oh my gosh, your child has autism.
Great advice. All right. Thank you, everyone. And thanks especially to Dr. Babbitt for joining us for this wonderful discussion this morning. We will hopefully see you all next week, where I believe we are talking about prenatal diagnosis and the laboratory tests associated with it. And have a wonderful weekend. And thanks again. Bye-bye.
Thank you so much. Bye-bye.